Okay, now we're going to talk about disorders of the larynx, and this starts on page 585 in your Iggy book. And we'll start with vocal cord paralysis, which results from injury, trauma, or diseases that affect the larynx, the laryngeal nerves, or the vagus nerves. You can prolonged intubation with an ET tube may cause temporary or permanent paralysis. Paralysis of both of the vocal cords may result from a direct injury, stroke involving the brainstem, or even a total thyroidectomy. Vocal cord paralysis may affect both cords or only one, and when only one cord is involved, which is the most common cause of vocal cord paralysis, the airway remains patent, but the voice is affected. But if you have symptoms of open bilateral, meaning both of the vocal cords are paralyzed, you would have hoarseness, a breathy, weak voice, aspiration of food. So bilateral closed vocal cord paralysis causes airway obstruction. It's an emergency situation if the symptoms are severe and the patient cannot compensate. And stridor is the major manifestation of that. So immediately notify the rapid response team if there's any dyspnea with stridor that occurs. Securing an airway is the main intervention. Put the patient in a high Fowler's position. Assess for airway obstruction. They can do a surgical procedure in which they use injection of Teflon into the affected cord so it enlarges toward the unaffected cord, and this usually improves that closure during speaking and eating. So the patient with open cord paralysis is at risk, of course, for aspiration because the airway is open during swallowing. We have to teach the patient to hold his or her breath during swallowing to allow the larynx to rise, close, and push the food back into the esophagus. You teach him to tuck the chin down and tilt the head forward during swallowing. The indications of aspiration include immediate coughing on swallowing of liquids or solids, a wet sounding voice, and tearing up or watery eyes on swallowing. And then we need a chest x-ray to diagnose aspiration pneumonia. I had a little one that I used to take care of when I worked in the school system that had a tracheostomy because he had vocal cord paralysis and, well, he had an injury and they had to take out his vocal cords. So he had a tracheostomy because of that. And, you know, of course he had trouble speaking, but he could communicate really well, and that was really the only thing that was wrong with him. So it was really sad that he had to have a trach at such a young age. Okay, we'll go on to vocal cord nodules and polyps in just a minute. Okay, now we'll talk about vocal cord nodules and polyps, and it's good just to know the difference. Nodules are enlarged fibrous tissues caused by infectious process or overuse of the voice. They often occur where the vocal cords touch during speech, and those people that are most affected are teachers, coaches, sports fans, and singers. Polyps are that edematous type mass that occurs most often in smokers and with people with allergies. So the main manifestation is painless, because nodules and polyps are painless hoarseness because of the lack of coordinated vocal cord closure. It's important that we teach the patient about smoking cessation, the importance of voice rest. It includes not speaking, especially not whispering, because it puts even more pressure on the vocal cords, and avoiding heavy lifting. Stool softeners are used to avoid bearing down during elimination, which closes the glottis. Humidifying the air soothes the cords and prevents overdrying. Speech and language therapy is used to help the patient learn to reduce speech intensity. And if the hoarseness isn't relieved by any voice rest or speech or in language therapy, the surgeon may remove the nodules or the polyps using laryngoscopy. You can do laser and surgical resection are used to remove the membrane of the affected cord. After surgery, the patient must maintain complete voice rest for about 14 days to promote healing. You can help the patient, especially preoperatively, that they'll use different forms of communication such as a slate, picture board, pen and paper, alphabet board, or a programmable speech generating device. It's always good to place a sign on the patient's door over the bed and on the intercom system to help implement voice rest. Okay, the next one we're going to talk about is laryngeal trauma, and this occurs with a crushing or direct blow, injury, fracture, or injury induced by prolonged ET, endotracheal intubation. Those manifestations include that difficulty breathing, inability to produce sound, which is called aphonia, hoarseness, subcutaneous emphysema, which is that air that's present underneath the subcutaneous tissue. You may have bleeding from the airway as well. Usually the healthcare provider will do a visual exam of the larynx by laryngoscopy, and then management of patients with this type of injury consists of assessing the airway, monitoring the vital signs, respiratory status, pulse oximetry every 15 to 30 minutes, airway priority with this type of patient, apply oxygen humidification to maintain the O2 sats. If you may see tachypnea, nasal flaring, anxiety, sternal retractions, shortness of breath, restlessness, decreased O2 sat, decreased level of consciousness, and stridor. As you know, stridor is not a good sign at all. Surgical intervention is needed for any lacerations of the mucous membranes, the cartilage exposure, and the cord paralysis, and an artificial airway may be needed. Okay, that does it for our diseases of the larynx.